CC220, also known as Iberdomide, is a new immunomodulatory or CELMoD agent. Essentially, this compound targets cereblon, which leads to the degradation of Ikaros and ileos via the proteasome. This in itself leads to myeloma cell death and immune modulatory effects such as T cell and NK cell activity. We've previously reported the first-in-human study of Iberdomide and Dexamethasone, and what we're reporting now are the expansion cohorts, cohort D, which is for patients who are triple-class refractory, so they are refractory to a proteasome inhibitor, an immunomodulatory agent, and a monoclonal CD38 antibody. And the next cohort, cohort I, which is a difficult-to-treat population of patients who've been exposed to a prior BCMA agent. Now, I would say that actually we have very little data on how patients who've been exposed to a BCMA agent perform. So this is the purpose of performing this study. So patients received Iberdomide at a dose of 1.6 milligrams for 3 weeks on, followed by 1 week off, with dexamethasone weekly until disease progression or intolerance. The overall response rate for cohort D was approximately 30%, and a similar sort of result was seen in cohort I. What we do see is that patients do deepen their responses as time goes on, and unfortunately on this study we lost some of our patients through COVID-19, and therefore they weren't able to deepen their response. The median progression-free survival data is approximately 3 months, and the overall survival data is not yet reached. But when we look at the median progression-free survival for those responders, they actually perform really well. So again, this is giving an indication that despite this being a heavily pretreated population, triple-class refractory, many patients penta-refractory, and I should add that the majority of patients were refractory to Lenalidomide or Pomalidomide, to get activity of a doublet, I think, is meaningful and impressive. In terms of the tolerability profile, one of the key things about Iberdomide is that it's only present as a pure form. And what we find with the thalidomide and lenalidomide is that different enantiomers break up of that compound, which leads to the sedative effects. We don't see that with Iberdomide. So when you look at the toxicity profile, there is some hematological toxicity, as we'd expect, but the non-hematological toxicity is very low. There were hardly any grade 3 or 4 events. So overall, I think Iberdomide and dexamethasone is a very well tolerated anti-myeloma drug. It has activity as a doublet in the hard-to-treat triple-class refractory populations and the post-BCMA patients. And I'm really looking forward to the future studies, which will be combinations with proteasome inhibitors, monoclonal antibodies targeting CD38, and also as used as a maintenance agent post-stem cell transplant.